Welcome to Coping with Parkinson Disease, From Everyday Annoyances to Behavioral Disturbance by Dr. Morgan Faeder. Dr. Morgan Faeder is a neuropsychiatrist from the University of Pittsburgh Medical Center. He works in the movement disorders clinic, and one of his specialties is Parkinson's disease. Thank you, Dr. Faeder, and I'll let you take it from here.
Great, thank you so much, Casey, and thanks everybody for being here today. So I'm going to talk about Parkinson's disease. I'm going to talk probably more about the behavioral disturbance than the everyday annoyances, because honestly, the people with Parkinson's disease are the people who are the experts in the everyday annoyances. We think of some of these things as minor sometimes, but they're really not minor, and can lead to lots of stress. Things like not being able to speak loudly enough to be heard, having difficulties with mobility and needing various mobility aids, constipation can be really not minor. And then, you can see actually from 1859, I think, this is the signature of a woman who had Parkinson's disease from then, and you can see just evidence of difficulty with writing, and so difficulty with communication can be a big thing. But as I said, you all are really the experts there. So there can be physical and cognitive and also sort of emotional or behavioral issues, right? And a lot of this stuff is attributable to the non-motor symptoms of Parkinson's disease. So Parkinson's disease is usually thought of as an issue with movement, right? So generally people have a tremor, or they're very slowed down, their movements are very slow, may have difficulty walking. And these are the things that we usually define Parkinson's disease as. You'll hear people talk about motor onset of symptoms, and usually the onset of the disease is correlated with or attributed to when the motor symptoms start. But the non-motor symptoms are a huge part of the disease, right? We've got everything up there from constipation down to dementia, and you can read everything in between. And many, if not most of these, are actually behavioral symptoms, right? So we've got an illness that is almost defined by the motor symptoms, and yet we're going to see that a lot of the problems that people have are going to be the behavioral symptoms that are core features of the illness, right? Which can get confusing for people, because when you think of something as being a purely quote unquote physical illness, but you've got all of this behavioral stuff that goes with it, it can be confusing both for people with the disease and caregivers, and other people just interacting, right? So when I see somebody, and I'm interested in helping them with behavioral symptoms of Parkinson's disease or other behavioral symptoms that may be unrelated, the first thing I want to do is identify what's the most likely cause. Why is this happening, right? And so it can get confusing, because it can be that somebody, for example, is having an episode of depression, and they've had depression earlier in their life, long before Parkinson's was even on the horizon. Or it could be that they started getting depressed and then they had their first motor symptoms of Parkinson's not long after that. Or it could be that they had motor symptoms of Parkinson's disease, never had any depression at any point prior to that, and sometime later develop some depressive symptoms, right? And so we have to tease out what of the, in this case, depression, is related to just the person had depression. We would call it quote unquote primary psychiatric, right? So this is just has depression aside from anything else. What is related to Parkinson's disease, and could be that then we see the depression is creeping in a little bit before that diagnosis, or it could be after the diagnosis, or it even could be related to the medications that we give for the illness, right? And so we have to tease some of these things out. Making it even more complicated, it can be related not only to medications, but it can be related to the timing of medications. So many of you are probably very familiar with needing to take carbidopa, levodopa several to many times a day, right? And the graph up in the upper right corner here is what it's labeled a typical day, but it's sort of what happens with symptoms as you take the, in this case, carbidopa, levodopa, and then have the onset happen, have it start to work, have it at its peak efficacy, and then have it fall off, right? And you're probably familiar with the take a dose, gradually that medication starts to work. We call this then the on time, when people are functional and able to do lots of things. And then as it wears off, they may have off times, right? So that lower part of that curve. And then we have a lot of symptoms that can return. And so are we looking at a medication effect in that the medication is actually treating the symptom that's related to the Parkinson disease, and that we need to move medications around, or do we need to start thinking about other things? And for reference later, I guess if you're watching this on YouTube, you can pause, or if I'm happy to send my slides out to anybody who wants them. You can see in the red box in that very busy table down in the bottom left, what typical relationship to the dopaminergic medication, or the medications for Parkinson's disease, these various behavioral symptoms will display, right? And so that can be pretty complicated, and we need to figure that out, which means it's really helpful if you pay attention to those things, because you can be related to a lot of different things. And so I'm going to talk about depression first. So about 35% of people with Parkinson's disease will at some point over the course of the illness have symptoms of depression. They may not have the full syndrome that we call major depressive disorder, but they may have some of these things. And so things like low mood or energy, feelings of guilt, feelings of worthlessness or hopelessness. They may have difficulty enjoying activities. And strangely, you can have either increased need for sleep or decreased need for sleep, or increased or decreased need for appetites, or need for food or appetite similarly. And what we're looking at there is basically a change in sleep patterns or a change in appetite. And then at its most severe, people can have thoughts of death or even thoughts of suicide. Right. And when we think about depression, we know that just general stress contributes to that. So life stressors, which can be related to or not related to the Parkinson disease. So it can be hard living with the symptoms of Parkinson disease, and that can contribute to depression. It actually can be the first symptom of Parkinson disease. So it can happen not very long before, say, the motor onset of the illness, and can actually represent the first symptom of the illness. So we know that in Parkinson disease, several of the neurotransmitters, so the molecules in your brain that convey information from one part of the brain to the other, are disrupted. And we also know that those neurotransmitters, in this case, mostly dopamine, but also serotonin, can cause depression. So it could be that your dopamine system isn't working terribly well, don't have tremor yet, or stiffness or slowness yet, but the first thing that happens is a noticeable decrease in mood. And then, so it could be the presenting symptom of Parkinson's. It could have a complicated relationship to the Parkinson's medication, so can fluctuate during the day with medications. And the treatment is going to depend on what we think is causing it, right? So if we think it's a depressive disorder that's not related to Parkinson's particularly, or maybe doesn't fluctuate with medications but is related to Parkinson's, then antidepressants are going to be the first line of treatment. But we can also do a lot of adjusting medications, moving medications around, to try to help with depression as well, depending on sort of the pattern that it takes. And then psychotherapy is good. I'm going to recommend psychotherapy to just about everybody. And just a word about that. Psychotherapy is wonderful, and it's not just getting stuff off your chest. Getting stuff off your chest is great, or venting is great, and friends and family can help us with that a lot of the time. But what you get out of psychotherapy is more than just that. The therapists use various techniques, which I'm not going to go into, but it's been shown in studies that therapy can have the same effect on the brain as medication can. And so it's actually causing changes in how the brain is working that can help alleviate symptoms like depression or syndromes like depression. There are things that may be related to depression or may look like depression as well, but aren't actually depression. And it's good to be aware of those as well. Demoralization can be one of those things. And people can be both demoralized and depressed at the same time, but they're not the same thing. Demoralization is more of an existential distress, a feeling that you can't control your circumstances, or that the ways that you've used in coping with difficult circumstances just aren't effective any longer. It leads to feelings of helplessness and hopelessness, but it doesn't tend to lead to things like feelings of worthlessness or guilt. It usually, you can tell the difference between demoralization and depression by asking, if your circumstances were better, how do you think you would feel? Or, if you're feeling hopeless about this particular aspect of your life, can we strategize around that to help improve that and help improve people's circumstances, the thing they're demoralized about? And that can often help without needing to go towards medication, basically. If we can basically make people's lives better, then they often will respond to that if demoralization is the issue. Fatigue is also not quite depression, is also really common in people with Parkinson's disease. About a third to 70% of people with Parkinson's disease will have fatigue as a prominent symptom at some point over the course of the illness. That's a very wide range, I realize, but nevertheless, it is quite common. And it can be caused by the disease, in fact, often is, or it can be caused by other factors, things like poor sleep. Depression itself can cause fatigue. And then apathy and fatigue are often related, not exactly the same thing. Unfortunately, we don't have any great treatments for fatigue. There are medications that are used for fatigue and other illnesses that, unfortunately, when we've studied them in people with Parkinson's, just haven't panned out as being terribly helpful. And then apathy is the last thing that's not quite depression, but may be related. And so apathy is more a loss of motivation. You can see decreased interest in activities like you can in depression, but you don't tend to see a lot of the other things that go with depression. So you'll see things like a decreased motivation or initiative, decreased interest in activities, or even decreased emotional responsiveness, which can really, particularly to the people around the person with apathy, make it look like depression. So they may not have, happiness or sadness per se. They may be just very, very flat. And about 40% of people with Parkinson's will experience apathy at some point. Earlier in the illness, earlier in Parkinson's disease, you'll see what we call motivational apathy. So people may just have that decreased motivation, decreased initiative. And it tends to go alongside of anxiety and depression. So often you'll see depression and or anxiety and apathy at the same time. And this kind of apathy tends to respond to treatment of the Parkinson's disease. So using medications that act on dopamine to treat the Parkinson's disease will often also help treat the apathy. And so we can go on, and as the Parkinson's advances, the apathy can change to some extent. It can be more what we call cognitive apathy. You don't need to pay attention very much to that graphic that's on the right. The only thing that it's intended to show is that this cognitive apathy that comes later is different from the motivational apathy that comes earlier. And unfortunately, that's because it tends to be due to lack of a lot of different molecules in the brain, or problems with those symptoms, or problems with those systems, and doesn't tend to be responsive to treatment with the medications that act on dopamine. What we can do for people who have this more advanced kind of apathy is do some education around making an environment where the person can be more interactive and be more involved in their life. And that usually requires caregivers to be kind of their external brain in this case. So they need to provide motivation. It's the difference sort of between asking somebody, hey, would you like to go see a movie, versus saying, hey, we're going to go see a movie now. And often the person with apathy will not want to go see that movie, but they also often will respond to somebody giving them that direction to go do that, and then can get some enjoyment out of it as well. Okay. And then the next thing, those are sort of the depression and depression mimics. Anxiety is the next thing that is really very common in people with Parkinson's disease. There's the worrier. This is the my anxiety gives me anxiety kind of person. Or even more to the point, I'm not worried right now and I'm worried about not being worried. Anxiety can have a lot of different kinds of manifestations. So there's the worrier who just worries about everything. There's somebody who doesn't tend to worry about everything, but may have just extreme anxiety come out of nowhere, hit them like a ton of bricks, and all of a sudden they're breathing really quickly. It feels like their heart is racing. They may feel like something is just extremely wrong, have this feeling of dread. And that's, what we call panic, which a lot of people will have experienced at some time during their lives and may be caused by things, or it may be something that just comes out of the blue. And that's just another flavor of anxiety. People may also have anxiety about very specific things. So it's really common to have social anxiety, and particularly in the context of Parkinson's disease, sometimes people will have social anxiety related to, say, worry about what people are going to think about what their appearance is, whether they may have a tremor that they feel is obvious and that people are going to wonder about, or maybe moving more slowly or need assistive devices like walkers or canes or things. And people can have a lot of anxiety about the way that they're presenting to the outside world and what other people are going to think of them because they may need some of that assistance. We also have just specific phobias, things like fear of snakes or fear of spiders, which isn't particular in any way to people with Parkinson's disease. But if you were afraid of snakes or spiders before, you're probably still afraid of snakes or spiders. And then we can have anxiety that's actually from the medications. And I need to put in a plug right now. If you do happen to be somebody who uses medical cannabis, the high THC versions of that can actually cause a lot of anxiety. And so I generally advise people to stay away from high THC or high potency medical marijuana, and if you enjoy it recreationally as well. And then, so about 30% of people with Parkinson's disease will at some point have anxiety. Again, just like depression, life stressors can contribute to this. And also like depression, it can be the first symptom of Parkinson's disease. So somebody who's never worried about much before suddenly starts worrying a lot, and then maybe a year or two later develops a tremor or starts moving very slowly. That anxiety may be a representation of the first onset of Parkinson's disease. It also has a relationship, sorry for the siren, you can probably hear in the background, can also have a relationship to medication, either on-off periods, or start of certain medications that can increase anxiety sort of all the time. We will often see a pretty clear pattern of anxiety being worse either at the peak of carbidopa levodopa on period or as it's wearing off. It's kind of interesting that it can be caused by too much or too little, basically. But again, we want to pay attention to timing and dosages of the Parkinson medications. Treatment, like depression, really also depends on what the underlying cause might be. And antidepressants are first line for anxiety as well as for depression. We also obviously adjust medications, as I just said, and then psychotherapy can also be very helpful for anxiety as well as depression. Okay, and now psychosis is also one of the things that comes often with Parkinson's disease, and it can be pretty scary to talk about and to experience. The psychosis that comes with Parkinson's disease tends to have a really specific, sorry, my computer's doing something weird. Okay, a really specific pattern to it. Often people will see something sort of out of the corner of their eye, they look and it's not there. Those things may be small things sort of moving in the periphery. I've had people tell me they thought they saw a cat, but then they realized that actually they had lost their cat several months ago, and so they knew it couldn't be a cat. And people generally know that what it is mind playing tricks on them, their eyes playing tricks on them, or a manifestation of their Parkinson's. The words that we use for these things are sort of soft signs. That's when people are aware of what's happening. You may hear something about passage hallucinations, which is that seeing stuff out of the corner of your eye, or also something that's actually really pretty specific to Parkinson's disease, which is what we call presence hallucinations, which is feeling like somebody's in the room with you when there's nobody there, or feeling like somebody's looking over your shoulder, which can be really disconcerting. Another one of these things is what we call illusions, which is mistaking one thing for another. So, for example, if there's a coat rack across the room from me and I think that there's a person there, then that's an illusion, right? I'm seeing the coat rack as a person. And then I may look over there and then realize, oh yeah, that's a coat rack. And so that's another thing. So it's basically when your brain is filling in information wrong. It's not that there's not something that you're looking at. It's that your brain is telling you it's one thing when it's really something else. About 15 to 30% of people with Parkinson's disease will at some point develop what we call fully formed visual hallucinations. And that's not the seeing stuff out of the corner of your eye. That's like seeing something right in front of you. And there are often hallucinations in other senses. Most common would be auditory hallucinations, so hearing things that other people don't hear. But there can also be, smelling things that aren't there, tasting things that aren't there, or so sometimes feeling something crawling on you that's not there. That's not as common as the auditory or visual hallucinations. Delusions, which are, if you think about psychosis in general, a very common manifestation of psychosis, if you look at all kinds of psychosis, are actually pretty uncommon in people with Parkinson's disease. So usually what we're dealing with is problems with senses and not problems with, for lack of a better word, problems with thinking or interpreting information. Okay, and so you don't have to pay too much attention to the graphics on this slide, just illustrating how medications and the neurotransmitters interact in the brain to either help or cause psychosis. But that's basically just to say that sometimes the psychosis is caused by the medications that we give to help with Parkinson's, and sometimes it's caused by the disease itself, which again is confusing. It's like, why is it both caused by the disease and caused by the thing that actually helps with the disease? Well, that's because your brain is a complicated thing, unfortunately, or actually fortunately, because it does lots of wonderful things as well. But that means that the first thing that we look at doing is adjusting the medications for the Parkinson's. It can be that we can make relatively small decreases or tweaks in timing of dosages in order to relieve some of those symptoms. The other thing that I'm always going to be asking is how distressing is this symptom to you? Because if it's not terribly distressing, or it's not distressing at all sometimes, then we don't necessarily need to give a medication or even adjust the Parkinson's medications to treat it, because there are always side effects of other medications. And if we adjust the Parkinson medications, sometimes that's going to lead to worsening of other symptoms of Parkinson's. So if we don't actually have to do anything about it, then we might just watch it for a little while. As long as somebody is saying, yeah, I see something over there. It looks kind of like a cat, but doesn't really bother me. I know it's just the Parkinson's disease and I can live with it. Then I won't necessarily say that we need to treat this. It's when people are distressed that we really want to start making sure that we're doing something about that. We can also use just environmental approaches, which is kind of setting up environments for people to be able to succeed. So things like at night, making sure that rooms are well lit, because it's a lot easier to have those illusions or even the hallucinations when the room is poorly lit. It leaves your brain too much room to kind of fill in the details, and it can fill them in wrong. We also then, when we do move into using medications, we'll start with the things with the fewest side effects first. So the first thing that we might use would be medications that we often use to help also with memory. So things like donepezil, which is also called Aricept, or rivastigmine, also called Exelon. Those things can help both with memory and thinking, and can also help decrease the hallucinations that people may be having. It's only after we've tried all of those things that we move towards using what we would call traditional antipsychotics, so things that we use for psychosis in other settings. And when we use these things with people with Parkinson's disease, we use much, much lower doses than we would use for somebody who has, say, schizophrenia or a truly like a psychotic disorder that we would treat in other areas of psychiatry. Just to give an example, with quetiapine or Seroquel, which is the one that we will usually try first, a starting dose of that might be 12.5 milligrams, which is half of the smallest pill that's available. Whereas in somebody with schizophrenia, we may be using up to 1,200 milligrams of quetiapine for that. So it's really, we're using very small doses and only as much as we need to give people relief. It's about 8 years ago that we got pimavanserin or Nuplazid, which is the only one of these that doesn't act on the dopamine system. So it's the only one that doesn't risk worsening of Parkinson's symptoms. And that one we will usually go to after the quetiapine, just because it's actually really, really expensive. It tends to work about as well as the quetiapine, doesn't have the same risk of worsening Parkinson's symptoms. But it also does take a little bit longer for it to kick in. It can take good 4 to 6 weeks to really see the effects of it. And so people often will have to wait to see if it's going to be helpful. If nothing else has been helpful, then we move on to using a medication called clozapine or Clozaril, which is the most effective. It's very effective medication, tends to be very unlikely to make Parkinson's symptoms worse. And unfortunately, it also has some pretty severe side effects or possible side effects, which means that we need to do blood monitoring in order to prescribe that to people, because we want to make sure that they're not having the most serious side effect, which is a decrease in one of the types of red blood cells that can make it hard to fight infection. The other side effect that we spend a lot of time considering is that it can cause really pretty bad constipation. And since Parkinson's can also cause constipation, we want to be really on top of that, because constipation, if untreated, can actually be really dangerous. And so we want to make sure that people are continuing to move their bowels. It's also very uncomfortable. And so those are the treatments that we will use for psychosis. The last behavioral sort of domain that we worry about with people with Parkinson's disease are what we call impulse control disorders. And these are pretty much exclusively associated with treatment of Parkinson's. So this isn't just one of those symptoms of Parkinson's that people may get. It's a side effect of the medications that we give to treat Parkinson's. So people with Parkinson's disease who aren't on any dopaminergic medication, so nothing that's affecting the dopamine system, have the same risk as I do of developing one of these. So just as same risk as the general population, which is low. And so, but the things that we will see, and everybody gets warned about these when we start the dopamine medications for Parkinson's, are things like compulsions to gamble or eat or shop, and even having compulsive sexual behaviors. And these can be very, very distressing to patients and families. Even though, we reassure people, this is not you, this is a side effect of the medication. When somebody does get caught in these behaviors, they can find it very shameful. And I just have to encourage people to report those to us, because we can do something about them. We can adjust medications to help make those go away. Those particular kinds of behaviors they're most likely with what we call direct dopamine agonists. So things like ropinirole or Requip or pramipexole or Mirapex are the most likely to cause those. And so we definitely warn people when we start medications like this. Also, it can happen with carbidopa, levodopa as well, and the other dopaminergic medications. But please tell us if you're having these, because it's not you, and we can do something about it. We can adjust the medications to make those things either much more tolerable or make them go away. The other one that's related is called dopamine dysregulation syndrome, and this one is people most at risk are people with high carbidopa levodopa doses. And this is compulsive overuse of the medications. And so it's thought that this is possibly an effect of the wearing off of the medication, and that the medication wears off for non-motor symptoms. So often it will be anxiety before it wears off for the motor symptoms. So people can feel like they need the next dose, but then take the next dose, and then it then kind of perpetuates itself in this cycle, because they're just consistently kind of overdosing themselves, because it always kind of feels like the medication is wearing off, even though it's not for most of the effects of the medication. And again, adjustment of the medications is what we do here. And also, people who are candidates for deep brain stimulation to treat the motor symptoms of the Parkinson's often will do really well, because then we can decrease dramatically the doses of the Parkinson medications, and get rid of these things completely by going down on those medications, because they need so much less of them after the DBS surgery. And so that's one thing to think about. Okay. I'm going to shift gears a little bit and talk about resilience, because I want to give you something to come away from this with, some things that you can do at home that can actually just help cope with some of these symptoms. And so resilience is, basically an internal resource that helps us cope with adversity, that, can be an ability to bounce back. The couple of graphics there, resilience, the one on the bottom, resilience comes from material science, I guess, actually. And so it's where the material is able to adapt to stress before it breaks. So when you run out of resilience is when the material will break. And it's actually really pretty analogous to how we use resilience in the sort of emotional or psychological sense, right? And related to resilience is vulnerability. And there's physical vulnerability, there's emotional vulnerability, and physical vulnerability is universal. Actually, both are universal. Everybody ages, everybody deals with illness, and those things make us more vulnerable to physical effects, right? We can have a physical reserve. So things like somebody who is used to running marathons may, have a lot of strength and a lot of aerobic capacity, and they may be able to deal with more insults to the system than somebody who doesn't exercise much. But it's not always protective. It can be helpful. And physical vulnerability causes a lot of emotional stress and is easier to handle with both internal and external resources. So internal resources being resilience, and external being, the ability to engage supports of various kinds. Economic assets, always helpful in dealing with just about anything. The emotional vulnerability is, as I said, also universal. And it's, related to the fact that everybody experiences difficult emotions. They're listed here on the slide, but, sadness, shame, helplessness, embarrassment, frustration, everybody goes through these. Resilience is really building confidence in the ability to deal with these things. And one of the things that gets in the way is that sharing vulnerability with other people is the thing that can actually increase resilience, but it also feels really risky, right? Because you worry about rejection, worry about letting people in that way, but letting people in that way builds connection. So it builds some of those external resources, and it also builds the resilience, that internal resource, your confidence in dealing with these difficult things. And so I'm going to go on to some helpful strategies about dealing with pretty much anything, but in this case, dealing with those annoyances and everyday difficulties of dealing with Parkinson's disease. So I'm not sure exactly how much you can see, but you're going to have to take my word for it. When I'm talking about deep breathing, probably a lot of you have heard about deep breathing and have probably been like, yeah, okay, I know how to do that. But we're going to go through it anyway, because it's extraordinarily helpful, actually. And the key is in doing abdominal breathing or belly breathing. Because when you expand that abdominal cavity, there are actually sensors in your abdominal cavity, so nerves basically, that lead back up to the brain that tell the brain to calm down, tell the brain to relax when they're stretched. So when that abdominal cavity expands, it's a signal to the brain to kind of take everything down a notch. And so that happens naturally when we're in a state of relaxation. You'll notice if you're relaxed, you tend to breathe more into your abdomen and less into your chest. But we can also kind of hijack that mechanism to help us deal with stressful situations. And so to do the abdominal breathing and just to get a feel for it, I'm going to do it, and I'm going to hope that you're going to do it with me. So put a hand on the chest and a hand on the belly. I don't think you can see all of that, but that's fine. And then when you take a breath in through the nose and out through the mouth, you want to feel the abdomen expanding and the chest not moving very much, right? So I'm going to do that a couple of times. So in through the nose and out through the mouth again. Okay. And then you can use a technique called box breathing to really use that belly breathing to good effect, right? And what you're going to do here is breathe in, and for a count of 4 seconds, hold that breath for 4 seconds, breathe out for a count of 4 seconds, and then hold it again in that position for 4 seconds. And honestly, the 4 seconds is not the key here. If you're somebody who isn't able to do that, it's fine. You can do it for less time. But the key is to have this sort of rhythmic breathing, and that breathing into the abdomen, holding a little bit, breathing out, holding a little bit. And so I'm going to do this a couple of times just to get the feel for it. So again, I'm going to put my hands in place so I know I'm breathing into my abdomen, and breathe in for 4 seconds. And then hold that for 4 seconds. Out for 4 seconds. And then we're holding here again. And then we're going to breathe in again. And hold it again. And out through the mouth. And hold it again. Okay, and then you sort of rinse and repeat. You can do that several times, and doing that for about 4 times will really kind of calm everything down. Other helpful strategies, mindfulness is really helpful. You can hijack that deep breathing again, or use it in another way. Also progressive relaxation. And with mindfulness practice, what you're generally doing, or this is one way to do it, is focus on your breath. You want to notice the sensation of the breath as you breathe in or as you breathe out. And it doesn't have to be any particular thing. It could be different things for different people that you're focusing on. Some people, it's the expansion of the abdomen. Some people, it's the feeling of the breath as they breathe in, like on their nostrils or in the back of their throat. And you just want to be breathing naturally, but intentionally. And as you do that, you can kind of observe your thoughts. And if you're like me, you're going to have lots of thoughts, and they're going to be kind of everywhere. And you're going to be needing to call your attention back to your breath. And that's fine. That's kind of actually what it's for, is to help focus the attention. So I would be sitting there doing my breathing, and then I'd be like, oh, I've got to give a talk tomorrow, and oh, they're going to record it and put it on YouTube, and I'm feeling really nervous about that. I'm like, oh, Morgan, you're thinking about things. Focus on the breath, and then go back there, and then you can keep doing that. And the good thing about this is it does help relax in the moment, but it also kind of teaches your brain how to keep yourself in the moment generally. And it can be really helpful in that you'll find that naturally you have some more ability to step back from situations, or to insert a pause before you react to certain things. So, if I'm driving, somebody cuts me off, and I may have the urge to make an unpleasant gesture or yell something, maybe I'll think before I do that, as opposed to just reacting. And that can be helpful. It can be helpful for lots of different situations that are stressful. Progressive relaxation is probably most helpful for sleep in my experience. This is where you do those deep breaths, and then pay attention to your body sort of from the feet up. Pay attention to each part for the length of a few breaths, and just relax that body part. You can relax your feet and then your legs up to your knees, up the thighs, etc. As you're doing some of that deep breathing, and you can find that it really helps relax the whole body and can be very helpful in helping people to sleep. Can be helpful sort of during the day as well if you choose to do it. But as I said, I find it most effective to help people with sleep. Other things that are helpful, and these are things that are often done by my colleagues in speech therapy or even occupational therapy. Some cognitive strategies, things like planning for the future, you can take a lot off your mind by using lists and calendars so that you've got those external things that are reminders of the things that you need to do. Planning for the future in terms of like financial planning and that kind of thing can also be helpful and reduce stress in the present because you've got those things taken care of. And so, as I said, my colleagues in speech therapy can really be helpful with strategizing for things that are helpful for any particular person, depending on what they're dealing with. And then the last one is exercise. And by exercise, I don't mean getting up and running a marathon, although if you do, that's great. If you're somebody who runs marathons. I did one once and it was maybe the most excruciating experience of my life. But exercise that you can do, that pushes you a little bit, but that you enjoy, can help in a lot of different ways. It helps how people are functioning in the present. It's the only thing we really know that helps prevent the progression of Parkinson's disease, and it improves mental and physical health overall. The pictures on the slide are, chair yoga is something that a lot of people enjoy. The Big and Loud program is really helpful, and it's big in terms of making big movements and loud in terms of speaking loudly, that can help with things that that people with Parkinson's can struggle with in terms of like soft speech and small movements, and really helps people function better both now and prevent some of that decline. And then on the bottom there is one of the Parkinson's boxing programs, which is also great in terms of not only getting exercise, but also building community, because you're with a lot of other people and sort of sharing the experience and helping to make those social connections as well. So both the exercise and the social experience can help people cope with symptoms and build resilience. And so that is what I've got for you today. And I'm pretty much right on time, which makes me happy. Thank you so much for listening, and I'm happy to take any questions that anybody might have.
Thank you, Dr. Faeder. We have one in the chat, and then are you okay if someone unmutes themselves and asks a question?
Yes, very much. I'm going to see if I can stop sharing the slides.
Sure.
All right, really, I am.
That's okay.
All right, I paused it, stopped it. There we go. I think that
There's
worked.
everyone.
Okay, great.
I'm going to share the question in the chat, and then we'll move on from there. And you can unmute yourself if you have a question. Dr. Faeder, do you use any of the available genetic testing products to determine the best antidepressant for an individual's genetic makeup?
That's a really good question, and something that I do get asked fairly frequently. I use them rarely, I'll say. There are some things that you get from those, some information that you get from that's really helpful. A lot of the information that you get from those panels, we can figure out by people's experience with different medications, and usually insurance doesn't pay for those panels unless you've already had several antidepressants that already haven't worked. And so we actually have a lot of information that'll show up in that report that we also have gotten because of the medication history. Sometimes it's really helpful to find out how people metabolize, folate, which is a vitamin, and that can actually be, the panels can be helpful with that. A lot of times, though, insurance doesn't pay, and it's probably not worth paying out of pocket for it.
Thank you. There's another question in the chat, which I will read now, which is, how does exercise slow the progression of Parkinson's? Besides the exercise that you will do, in a perfect world, what is best? Aerobic, weightlifting, combo, etc. Okay. What is the best one to slow the progression?
Okay, really good question. I do not know the like the exact mechanism in the brain of how it works. Um, so we know that it does work, but I could not explain to you all of the different interactions that are happening there. What I can say is that in an ideal world, you would do a combination of aerobic exercise and weightlifting. And the aerobic exercise that we have the most information about is actually things like boxing. So it's repetitive movements that are like boxing. That have the most evidence for them. That said, if you don't like doing that kind of exercise and you like another kind of aerobic exercise better, I would say do the thing that you like to do, because it's most likely that we just don't have evidence supporting other kinds of exercise. It's not meaning that we haven't studied them, as opposed to that other kinds of exercise aren't going to be helpful. Um, you know, weightlifting is in moderation, everything in moderation. We don't want you deadlifting heavy things. Although if you do that, actually, you already do that, that's fine. But you don't want to take that up just to help prevent the progression of Parkinson's. But anything that keeps you strong is going to protect you against things like falls and things like getting hurt when you do fall. And so that's, yeah, basically a combination of things.
Thank you. You're welcome to use the chat, or you can unmute yourself and ask a question.
When it comes to carbidopa, levodopa, how do you determine dosage where there's a positive impact on being physical, but there's a negative impact by being sluggish, which gets in the way of some of the other recommendations that you have made about, being positive and, doing what you need to do to manage your Parkinson's?
Yeah, also really good question. A lot of that is done by trial and error, unfortunately. And so making sure that you're reporting any side effects or any symptoms that you're having is going to, and as much as you can, how those vary throughout the day, particularly with relationship to when you're taking medication, can be really helpful for us in the clinic to figure out whether we need to move things around. Sometimes it's possible to decrease the dose of one thing and increase the dose of another thing to sort of try to balance those things out, but it's going to be very specific to the person and what they're experiencing.
Okay, thank you.
I have a quick question, Dr. Faeder. Sure. If you are not a patient and of one of the movement disorder specialists of UPMC, are you still able to see someone like you?
Unfortunately, not. Well, someone like me maybe, but not me specifically.
Or you,
unfortunately. Yeah, no. Yeah, because of the way that I get paid, I'm hooked. Hooked. That's not the right word. I'm attached to the Movement Disorders Center here with UPMC, and yeah. So, but there are. I'm trying to think. I'm trying to think if there are other neuropsychiatrists I know in the community. There are behavioral neurologists in the community there's at least one person affiliated with Allegheny Health, and I'm trying to think if there are others who do similar things or who can do similar things to what I do. And I could probably come up with a referral if you gave me enough time.
Okay, thank you. And once you have psychosis, does it ever fully go away with treatment?
Okay, another good question. And as usual, not a simple answer. If the psychosis is caused by the medications, then we can get it to go away. Whether it will go away completely and forever is unclear. That's going to depend on the person. If the psychosis is caused by the disease itself, probably it won't go away. Probably we can just manage it to make it so that it's not distressing. I mean, we can have people have remission in their symptoms, but as the disease progresses, it's fairly likely that it will come back. And our goal is going to be to, optimize the patient's experience rather than actually getting rid of it completely.
Okay.
Thank you.
Oops.
Do you have another question, Sally?
Well, yes, I was trying to figure out, think through the question, but how do you tell what's medication psychosis as opposed to neurological or Parkinson's psychosis? Is it just trial and error or what? Or can you tell?
We can tell a little bit based on what you tell us about when the symptoms happen. I mean, sometimes we will see somebody experience a psychosis when they have an increase in their medication, and then we're pretty certain that it's related to the medication. Or if it happens, right after you take a dose of a certain medication, then often we can be pretty clear on that being caused by the medication. Sometimes it's hard to figure out unless we play around with things and then trial and error.
Okay. Okay, very good. You okay?
Mm.
Any other questions? Oh, here we go. Are you involved with the testing for qualifying for DBS? If yes, how often are things like dementia discovered that a patient's families weren't aware of?
I am involved, although I don't see everybody who comes, who's a candidate for DBS. But when there is some suspicion of either somebody not being able to cope very well with the surgery and the stresses around the surgery, or cognitive problems, or possibly psychosis, then I will see people. And so when I see people, it's often because those things are already suspected. So I will be more likely to see somebody where we discover something like that the family wasn't aware of than just if I saw everybody who came in for DBS. And so it does happen. Usually people have a suspicion that there's something going on. The times when family might not be aware are times when family's not terribly involved with the patient to start with. Then they might not know if they're sort of infrequent caregivers, but usually people have an idea that there's something going on.
Thank you. Do you mind touching on drug-induced Parkinsonism and just some of the similarities and differences with?
Oh yeah, yeah, sure.
Thank you.
There are many medications that can cause drug-induced Parkinsonism. The major culprits are going to be antipsychotics. So medications like, I'm trying to think of the ones that most people think about now. Abilify or aripiprazole is the generic name of that. Risperidone, Risperdal, olanzapine, Zyprexa. Trying to think of Rexulti is one that is there are a lot of ads for right now. So medications like that, and the way that they work targeting psychosis is to interrupt the dopamine system. And so because of that, they can cause drug-induced Parkinsonism. And then when I see people where that's suspected, sometimes we will gradually take people off those medications long enough to figure out if that's what's causing it. And then we have decisions to make about, is this medication of enough benefit to you that it's worth the side effect that you're experiencing of the Parkinsonism? And that's the very individual discussion with people. Sometimes we can find other medications that do the same thing that that one was doing, and not have the same side effect. And sometimes it becomes clear that they really need that medication, and then it's, so how do we handle that side effect?
Thank you. I think we have time for one or two more questions if anyone has another question. Well, I think you covered quite a bit today. It was very helpful, Dr. Faeder. Thank you very much.
Thank you all for listening. I appreciate it.
And we'll see all of you again soon. Thank you, Dr. Faeder, and thank you everyone for joining.
Take care, everyone.
Bye. Goodbye.